for joining us for our Think Global event today. I'm Mary Brophy-Marcus with the communications team at the Duke Global Health Institute. Today's theme is While You Were Away, Global Health During the Pandemic. The issues that global health researchers and clinicians work on and worry about have not gone away during the COVID-19 pandemic. And today, our four panelists will explore the challenges of preventing and treating diseases such as cancer, HIV, and mental illnesses during the pandemic. They'll discuss new emerging problems caused by COVID-19 and lockdowns. And if time allows, we'd like to hear from them on a more personal level about their own personal growth and learning experiences this past year as a global health professional. For our audience, please feel free to ask questions in the Q&A section of this webinar at any time. Now, let's introduce our speakers. We have Megan Huchko, an associate professor of obstetrics and gynecology and a faculty member of the Duke Global Health Institute. A practicing OBGYN, Dr. Huchko's research focuses on optimizing the diagnosis and treatment of cervical cancer among vulnerable women in settings where health disparities occur. In a typical year, Dr. Huchko spends a significant amount of time in Kenya, and today she's talking with us from North Carolina. Our next speaker is Tolu Oladele, and she's speaking with us from Lagos, Nigeria. Dr. Oladele is an assistant director of the Health Sector Response Support Division in the Department of Community Prevention Care Services at the National Agency for the Control of AIDS in Nigeria. A physician with a specialty in obstetrics and gynecology, Dr. Oladele also has a diploma in international health and policy evaluation and a master's of health economics and policy. Prior to the pandemic, she was a fellow with the DGHI Center for Policy Impact in Global Health. And then we have Eve Puffer, an assistant professor of psychology, neuroscience, and global health at Duke, as well as a licensed clinical psychologist. Dr. Puffer's research focuses on community-based interventions that promote child mental health and improve family functioning and prevent HIV risk behavior. Much of Dr. Puffer's work is based in rural Kenya, but she's also an investigator on multiple studies in Thailand, Ethiopia, Liberia, South Sudan, and Iraq. And our fourth panelist is Kristin Schroeder, who's speaking with us from Tanzania. Dr. Schroeder is an assistant professor in pediatric hematology and oncology at Duke and a faculty member with the Duke Global Health Institute. A pediatric oncologist, she travels back and forth regularly to Tanzania to provide pediatric cancer care to children there. Dr. Schroeder's research focuses on creating interventions to improve pediatric cancer treatment and outcomes in low-resource settings. And she's having a little bit of tech issues, so bear with us if there are any problems there. Now let's turn to our panelists and hear more about them from them and their current global health work. And we'll start with Dr. Schroeder. Oh, we may be having some tech issues. So
can you hear me?
Oh yeah, we can hear you. You go ahead, Kristin.
Okay. So I apologize, I'm in Tanzania at the moment, and so having some internet issues. But as she said, I'm a pediatric oncologist, and I completed my global health fellowship through the Hubert Jürgen Center at the DGHI in 2014, 2016. And then in 2016 joined as an assistant research professor in the DGHI. And I spend 6 months per year here in Tanzania, where I am developing both clinical and research capacity, specifically focused on pediatric cancer, but in oncology in general. Yeah.
Thank you so much. Our next introduction is with Eve.
Sure. Hi, everyone. It's fun to be here. I wish we were in Trent 040 so I could see all of you, but it's fun to talk about this and hear about the other panelists' work as well. So yeah, I'll talk a little bit about my career path and what I'm doing, and then how we pivoted to be working on different things in this context. So I'm trained as a clinical psychologist with a focus on treating children and families. And as a PhD student, I did most of my work in pediatric neuropsychology, but then transitioned to doing global mental health work actually after my PhD. In 2008, I guess, I was DGHI's first postdoc. So I've been in global mental health for about 12 years now. And I started my work in rural Kenya with Duke. And that work was related to mental health and family relationships and how those are related to HIV risk. So I worked with community members there to develop a program to strengthen family relationships and through that reduce HIV risk among adolescents. And then after my postdoc, during which I lived in Kenya for about a year through an NIH fellowship, I decided to transition to the International Rescue Committee, which is a humanitarian organization, and serve as one of their research advisors. And there I worked primarily on child protection and parenting programs to develop those and lead randomized controlled trials of those interventions. And I also worked on some studies related to intimate partner violence, which were some of the other locations that Mary mentioned. But my parenting work was in Liberia, Thailand, and Ethiopia, and I continue to collaborate with the IRC. And then in 2012, I was excited to come back to Duke as an assistant professor in the Department of Psychology and with a joint appointment in DGHI. And since then, I've built a program of research in Eldoret, Kenya, where DGHI has a lot of strong partnerships with which many of you know. And with my collaborators at Moi University, we've developed a family therapy program, and that's for more highly distressed families. And we train non-professionals who have no mental health background to conduct family therapy through community-based organizations like religious congregations, where we've worked quite a bit. So my work now is to evaluate some of those programs and on the implementation science side to figure out how we can sustain and scale those up long term. So a lot of that has been on hold. We had big plans with my students and for myself to travel this summer and this fall. So we've had a big gap in time, but have been able to transition to some work related to COVID that I can talk about a little bit later.
Thanks, Eve. We'll definitely circle back to you to hear a little bit more about your work with students. Tolu, tell us more about yourself.
Thank you so much, Mary. I'm happy to be here today to be part of the panelists. My name is Tolu Oladele. I'm a Nigerian. I work at the National Agency for the Control of AIDS as an assistant director at the Department of Community Obstetrics and Gynecology. I graduated from the 2014, but in between I obtained a master's in health policy and economic evaluation from the University of Adelaide. At the agency, my work covers, I provide oversight function for implementing partners. I support the mobilization of domestic resources, working with the UN agencies.
We're having a little bit of trouble hearing Tolu. Let's just give it another second. Tolu, I don't know if you can hear us, but we can't hear. So for now, I'm going to move on to our next panelist, Megan. Hopefully Tolu will resume connectivity in a minute.
Okay, So I don't want to talk over her, but hi, I think many of you guys know me. My name is Huchko. I'm in the Department of OBGYN. So like Tolu, I am a clinician, and I, after my residency in New York, went out to San Francisco to do a fellowship in HIV and AIDS prevention studies and reproductive infectious disease, which brought me to Western Kenya, where my mentor has had started a HIV care program in partnership with a woman from the Kenya Medical Research Institute. And so I started working there about 13 or 14 years ago, and have continued working with the two of them as I stayed at UCSF and made the transition to Duke about 4 years ago. So one of the great things about the fellowship was that I had great mentorship, and they really talked about the importance of being on the ground, and gave me the opportunity to live in Kenya for the first few years of fellowship and then on to early faculty. So I spent that time on the ground working in Kisumu, which is one of the largest towns or cities in Western Kenya, developing and analyzing different strategies for cervical cancer prevention, both within HIV care clinics and in Government of Kenya clinics that are supported, that are in high HIV prevalence areas. So we sort of, our strategies evolved as the WHO and the cervical cancer communities evidence and recommendations have evolved. And most recently, we have just completed a 5-year, or I guess 6-year cluster randomized trial looking at different implementation strategies to provide cancer screening within the community and linkage to treatment at clinics, and trying to adapt as many ways as possible, ways to bring some of that treatment, to decentralize the treatment and bring it to women as close to where they are and as possible. And so that experience has really spawned a lot of different work. We learned a lot about infrastructure and logistical challenges, and how uptake, while they impact access of care, decisions about uptake of care are really influenced by a lot of additional factors, sort of the intangibles. We're now working to develop a framework to explore HPV-related stigma, and cervical cancer stigma, and to see how that interplays with what we know is a fairly high level of HIV-related stigma. We're looking at service delivery factors, like working with community health volunteers and the support they need to ensure that their messaging is consistent and correct, that they feel supported and confident. And then we've worked with some Duke students to develop some innovations to help us with that, where we developed a tool, a digital app. Actually, a group of computer science students here developed the prototype for an app that we've continued to build on. And the Ministry of Health has actually decided that they want to adopt our app. That timing, that decision happened at a meeting with them in late February. So as you can imagine, when my DGHI scholar and I were there for a week planning our summer and new projects we were going to work on, initiating this this relationship and figuring out how we would engage with their developers, and what's the function of the app, what's the right for the app, how do you even turn over and adapt code. I am not the tech person. And so all of that sort of came to a grinding halt a few weeks later, and the last 6 months have really been a period of adaptation. And my other hat is running the clinical research unit in the OB department. So there's been a flurry of work thinking about how research is done safely and impactfully here at Duke. But at the same time, we've had a lot of opportunities in Kenya to continue the work, and really, rather than, I think some of us were sort of shocked at the beginning and thinking, we'll wait till after COVID and after this ends, but really, you know, COVID has had such a profound impact on the lives of people there and the way services deliver that, you know, we've taken this opportunity to look to see what, you know, what is the healthcare infrastructure going to look like now? How has this impacted care for the reproductive health needs or the cancer needs of patients there? And what can our team do to both examine this and you know, work with the partners there to and reimagine healthcare for the COVID era and the post-COVID era? And can we see this as an opportunity in addition to the obvious challenges it's facing?
Thanks, Megan. Tolu, let's go back to you. Are you able to hear us, and can we hear you?
Okay, I dropped off. I wasn't sure if you heard me. Okay, so good afternoon, everybody. I'm glad to be here today. I'm an obstetrician and gynecologist by training. I finished from the University College Hospital Ibadan in Nigeria. I work with the National Agency for the Control of AIDS as an assistant director at the Department of Community Prevention and Care Services. Much of my work is into policy development. We adapt guidelines for the country based on WHO recommendations, and then we develop training manuals, operation manuals for the effective implementation of HIV in Nigeria. Then we also mobilize resources for the country. I work with the technical staff from the WHO, UN agencies to apply for global fund grants. And then I also provide oversight functions to facilities to monitor and ensure that effective
I'm sorry to see that Tolu is again having issues. Tolu, if you can hear us, we can't hear you. Your screen froze. Oh, there you are.
Did you get me?
We lost the last 30 seconds, but if you want to pick up where you left off.
Okay, I said I also provide oversight functions to facilities and state government officials to ensure, and capacity building to ensure that effective HIV services are delivered across the country.
Thank you.
Sorry, my network is quite bad today.
No, we really appreciate you beaming in, and we know that was expected, so no worries. Let's start back with Kristin. All of you are working with community partners in other countries. Kristin, let's talk a little bit about how COVID has disrupted or changed your normal work environment, you know, how it's affected you and your partners, if you want to dip into that a little bit.
Sure. So my world is sort of split 50-50. So I work obviously at Duke half the time in clinical capacity and in pediatric cancer, as in many cancers, COVID doesn't stop that. And so you continue to have new cases all the time. And so to work, you just have a few more screenings and things we have to do. In Tanzania, because I was here mostly in a research capacity, I had to leave the country early in mid-March, and then I wasn't able to return until August. And I'm one of 2 pediatric oncologists in the country. And so when I'm not able to be here, there isn't anyone else in the region that actually is trained in pediatric oncology. And so it puts a significant strain on us. Part of what I've been doing for the past 6 years that I've been here is training a staff on how to provide care for children with cancer. And so I've been using a lot of patient navigation and community coordinators and social workers and various other team members, including my current research staff, to train them on recognizing pediatric cancer, working with creating liaisons within to the hospital so we can get early referrals, working in the communities. And so what happened as a result of COVID is, on the research front, I have several clinical trials and things here. That all had to stop because the country, the National Institute of Medical Research here, mandated that all clinical research had to be paused. And so for about 3 or 4 months, we weren't able to recruit any new participants, but we just continued to follow our patients who had been enrolled in our trials. But from a clinical side, what we had to do was drop our staff down to 1 person at a time in the office. And that had significant impact because this team basically is responsible for providing the care for all new patients. And we have about 200, 220 new diagnoses a year, which meant that when we only dropped down to 1 staff in the office at a time, people were being missed. We weren't finding the new diagnoses. They weren't being referred. The patient navigator usually provides education to the patients. Well, when they have 10 people waiting to be seen, and you're trying to get people through, there wasn't time to provide education. So we're seeing abandonment of care. We're seeing, we had to divert our funds that we get. Everything that we do here is paid through a nonprofit. And so a lot of the funds that we had to be diverted to buy masks, to buy gloves, to buy chemotherapy. Chemotherapy was shut down. Most of our chemo comes from India, and it's almost all generics. Pediatric cancer treatment is 50, 60 years old. And so there isn't anything that's like cutting edge that we use in Tanzania. It's all, you know, standard treatment. And so most of that comes from India. And when COVID hit, all the flights shut down. So we had to scramble and buy all of the chemo that we could within the region for all of the children who had cancer between our consortium that we have here in Tanzania for pediatric cancer treatment. And so to make sure that we could provide care for kids until those airlines and ability to ship chemotherapy started again, which was about a month ago. So it was a huge strain on just sort of the clinical care. The research paused, but I think the biggest impact for us was really taking care of the patients suffered.
Thanks, Kristin. It just sounds like a tremendous, it's had a tremendous impact. Let's hop over to Tolu again, because I just want to make sure you get to speak in case we get disconnected. Nigeria had some major funding shifts when COVID hit. Can you talk about how that, the reallocation of health funding impacted your HIV work and systems?
Okay, so with the COVID, with the COVID pandemic, Nigeria experienced like a double shock because there was a fall in oil prices at the same time, and then because the production lines across the globe were cut down, the demand for oil was low. So apart from the COVID, the oil revenue fell, and that accounts for like 90% of the country's foreign exchange earnings. And with that, there was a need to revise the budget. And in revision of the budget, what was done was that funding was cut to health. We have what we call the Basic Healthcare Provision Fund, and that Basic Healthcare Provision Fund is to ensure that there's a minimum package of services across the primary health centers. And one of the services that is supposed to be part of this is HIV testing across the facilities. So with the COVID and the loss in revenue, what happened was that funding to the Basic Health Provision Fund was cut, not directly to HIV though, but you know, there's no how it won't impact on HIV. If a cut of about 43% occurred, that means that the little fund that is available now will be definitely overstretched in the country. And then what we also experienced was that there was need to move resources in terms of infrastructure to support the COVID response. Many of the facilities were that we use for HIV services now became facilities that were now isolation centers. And many of the HIV labs now had to be used to run COVID samples, and those affected viral load testing within the country. So in terms of direct funding to HIV, kind of we were lucky in terms of the fact that there was no direct cut like that, but definitely with the focus now being on COVID, we are just teetering on the edge and hoping that our funds for HIV are earmarked, and there will be no need to withdraw from what has been earmarked from there.
Thank you, Tolu. Eve, let's come back to you. Tell us a little bit about the work, a little more about the work you were doing in Kenya, and how that's been affected by the pandemic. You talked to me prior to this panel a little bit about your partnerships with various organizations and church groups in Kenya, and how you worked with lay mental health providers. Have those relationships continued?
So yes, we train lay providers often within existing social structures. So over the past few years, we've worked with religious congregations which have very strong infrastructure in the locations of Kenya where I've worked. They sustain a lot of programs that relate to psychosocial well-being and have values around supporting families. So we've worked closely with congregations to embed our intervention within their structure, within their routines. And that means training providers from within their congregation who have no mental health background, but they do have background in supporting other families. They're trusted members of the congregation. And so when we travel, we do in-depth training with our collaborators there, and we have very close supervision. We have some programming that happens actually in the church at the congregation level, and then we have in-home family therapy. And so a lot of that depends on being able to meet together for them to support each other, for them to receive ongoing training and supervision. So that cannot happen right now in a safe way with many of the large group portions that we have. Luckily in our work, the timing ended up being good from the point of not having as many mental health safety concerns, because we were in the middle of training a cohort of lay providers, and we had trained them in the prevention group-based intervention that would happen in the whole congregation, but we had not trained them yet in the in-home family therapy, meaning that we did not have families who were very high risk enrolled in the program at that time. So our training and even the prevention program are on hold until because extended group meetings in churches is not, of course, safe at this time. So it's unfortunate that we've had a pause. Our lay providers, we also have set up as sort of savings and loans groups amongst them. So they're continuing to be engaged with one another in very small groups where they're able to engage in that small economic activity together. But otherwise, we've been trying to work really hard to maintain personal relationships and check-ins, but really not able to continue with that. So we've been involving our research staff who are still employed in data analysis and writing, things that they didn't have time for before. So we're trying to find small silver linings. But I have a lot of students who are disappointed to not be able to meet that team in person and experience some of the training there.
Thanks, Eve. We are going to talk in a few minutes about your student relationships for those of you who do work with students. I just want to pop back over to Megan. You had brought up your research on stigma surrounding HIV and HPV, and mentioned a little bit about how now there's this added layer of COVID stigma. Can you talk about that a little?
Yeah, so we have a grant to look at how to develop a framework for how HPV-related stigma may work, and then how it impacts uptake of services, both cervical cancer prevention services and HIV care services. And so now, since the model of care has been so incredibly disrupted by COVID, clearly there are a lot of systems level factors, so clinic shutdowns or disruption of services, but that impact women's ability to access the services. But now there is likely an overlying COVID-related stigma that's impacting people's fear or willingness to go to get services. So we actually, as we continue to evaluate the data that we got before the shutdown, we really want to figure out a way to look at how COVID is impacting how women and families decide to access services. We just got funding to work with the government to help expand HPV screening in the communities and HPV vaccination. And so we're trying to incorporate stigma reducing service, health services in the way that we offer these. But I think this is an opportunity for us really to look at what are the short-term effects of the fear and potential COVID-related stigma, and I think the long-term effect on people's trust and relationship with the healthcare system. I see patients here, and I, ask patients at least once or twice a week what delayed them from coming into care. For instance, I had a patient that didn't come into care until she was 28 weeks pregnant, and she said she was afraid to come to the hospital or the health department because of COVID. She just didn't want to be any part of that. She had children. And so we're certainly seeing that here. I don't know that I don't know that we have any studies yet that have talked about the impact of that. But I think as we think about what the healthcare system is going to look like, as we don't really even understand the trajectory of COVID in Africa yet. Which way is it going to go? When are we going to get a vaccine? How are things going to be different there than they are here? We need to think about, how do we address people's fear and stigma around healthcare access?
Yeah, and you also mentioned that there is a current outbreak at the...
Yeah, so we had just been on the verge of doing some reopening, similar to our phased reopening here at Duke. They were offering, the Kenya Medical Research Institute was offering the opportunity to amend the studies, and using PPE and distancing measures, go back into the clinic to do some recruitment. And as we submitted our amendment to do that, there was unfortunately an outbreak in the healthcare facility we're working at in Kisumu. And, one challenge, I think, of being here and not there is the multiple layers that are between me and information. So it feels like my staff doesn't have a real understanding of what are the safety precautions, what are the next steps. And so it's hard for us to make plans while, of course, prioritizing staff and participant safety. So, yeah, and this is the clinic that I've been working with in Western Kenya for many, many years now. And it is a little nerve-wracking to think that now they've had a number of staff who've tested positive there. So, it contributes to the unknown of when we should restart and how we should restart research activities at this point.
Yeah, and I know you must have a deep, or just being so connected to your team there, that must take kind of an emotional toll too. You're concerned for them. going back to the topic of stigma, Tolu and Kristin, Kristin, I see your screen is off, so I don't know if you can hear us, but I'm really curious about COVID stigma in your respective locations. And Kristin, let's start with you, if any.
I think the only COVID, so Tanzania is interesting in that it has been declared COVID-free for about the past month or so. When the COVID outbreak first started, the stigma that I saw was more of against foreigners than it was people who had the disease. There was a strong belief that Tanzanians did not get COVID. It was not really something that was here. It was brought from places, including Kenya, and then abroad. And so many people who were here felt a lot of pressure to not leave their house, who were foreigners living in Tanzania, because they would get, there's a lot of harassment in the area because of it. As far as people who have COVID, Tanzania, one of the really cool things about living in this region is because there's such a strong public health infrastructure that's been developed through HIV, through Ebola, through various public health crises that have come through. The moment that COVID was found in Arusha initially, and then in Dar es Salaam, it went like very quickly, things sprung up. So we had massive education campaigns that went out, hand washing stations popped up in the hospital overnight, mandatory masking. They took it incredibly serious, and things really kind of shut down. There were definitely problems, but people who were tested positive for COVID, it was not so much of a stigma that we saw here. It was just more, they were quarantined very quickly. And because of the messages that were coming from the government, people who had COVID, it was sort of brought up as being not as serious. And there are great cures and things that you can do for it. And so there was never really a stigma against the disease itself. It was more against the people that were perceived to have brought it to Tanzania.
Wow, that's interesting. Thank you. Tolu, let's talk about stigma in relation to HIV in Nigeria.
Okay, I think over the years, stigma against HIV has improved. At the initial stage, definitely when there was no drugs, when the disease was in its early days, there was a high level of stigma, but the agency has worked with a lot of its partners, and thankfully now that science has improved over the years and HIV now is more of a chronic disease, there's not much stigma like the previous years against HIV, because now people know that you can have HIV and live a very productive life. And with the message out there about adherence, use of your drugs, and the novel strategies like pre-exposure prophylaxis, the stigma has gone down for HIV. But what I would say is that at the onset with COVID, there was also some level of stigma, especially when you cough in the public. People were worried that, are you sure you are not someone who has the COVID virus? But luckily in the last few weeks, we have been the Nigerian Center for Disease Control has been monitoring the figures, and we've been seeing a drop. We believe part of this is because maybe the transmission is being curbed, even though there has always been the challenge of adequate test kits, to test the number of people. And then with the messages out there being rolled out by that same agency in collaboration with my agency, people are adopting the right measures like hand washing, like social distancing, and the use of face mask is mandatory in public places. And I believe with this that the stigma associated with COVID will also go down.
And so it's, when it comes to getting medication for HIV, so has stigma not kept people from getting medication? Has it more been about drug dissemination then? Like, how is COVID affecting treatment for HIV? Is it more an issue of getting supplies and treatments at the grassroots level versus stigma that keeps people from clinics?
Okay, so I would say it's a lot of things. Stigma is there, like I said, but it's not as it was in the early days of the HIV epidemic in Nigeria. So stigma is still there, but it's not as bad. But like with the COVID, there was a shutdown of the airways, and therefore drugs couldn't come into the country as at when due. Then we also had the issue of movement restrictions, curfews within the different states. So people were also afraid of, so people couldn't come to the facility. And then with the fear of catching COVID, people weren't willing to come to the facility. So the things that we needed to do at that point in time was to find ways of reaching and making sure that people had access to their drugs. And one of the strategy that we deployed was the multi-month dispensing, which people were called in as soon as we started seeing that there was going to be a nationwide lockdown. Phone calls were made to patients to come into the facilities, but it was spread out so that the facilities too were not congested, and people were given as much as 3 months, 6 months drug to go away with, so that even though there's movement restriction and lockdown, people could have access to their drugs. But there were some delays due to the COVID virus, and then COVID pandemic, sorry. And then some people were not willing to come to the facilities, but efforts were made to reach them through the phone calls. And then we had a network. We leverage on the community of people living with HIVs, so that some of them would come to the facility and pick up drugs for a number of people, so that you don't have to see everybody, but you are sure that everybody gets access to the drugs. And then also as an agency, we had to write out letters, create waivers for those such community members that were serving as volunteers at that time, to help us make sure that people get access to their drugs.
Thank you, Tolu. That's very interesting. Now we're gonna pivot to student work, and a lot of you are involved with students at Duke, and bringing them into your research, and in past years they've traveled with you or worked with your teams overseas. Eve, let's talk a little bit about how you've compensated for the inability to put students on the ground. And I wanted to talk a little bit about your North Carolina research and what you're doing there.
Sure. So I typically work with PhD students in clinical psychology, Masters of Science in global health students, and then undergraduate students as well. And what they're interested in is global mental health on the surface, but underneath that is an interest in training non-professionals, understanding how to scale and sustain interventions for people, regardless of locations, that have very low access to mental health care, whether that's prevention or treatment. And so we've been trying to foster that broader perspective, and we had some funding opportunities in the Department of Psychology for students that's usually used for travel funding and conference funding, and they repurposed that for funding small projects related to COVID-19. And so my PhD students applied for that, and we started an online survey study to look at families in the US South and how the experience of COVID had influenced their family relationships, child mental health, adult mental health, sort of looking at the whole family system and the ways that this experience is impacting them. And then we had another opportunity through DGHI, recognizing that some of the pathways through which people get mental health care and support for their families had been very disrupted by COVID-19. It puts families in a bit of a pressure cooker, spending much more time together, placing children more at risk if their families are violent or if they're living in very harsh environments, for example. But there aren't enough resources to support families, first of all, and that's always present. And second, there aren't models of care that are consistent with being adhering to safety protocols during COVID. And so DGHI commissioned a research project asking us to explore how we might take lessons learned from the task shifting training non-professionals in Kenya and apply some of those lessons here. And also look at the family-based interventions that were appropriate for those types of task shifting and partner with community organizations here in North Carolina to explore the implementation and evaluation of those. So we are now at the beginning stages of forming those community partnerships with organizations who are already serving families. So that those include nonprofits, those include religious congregations and other faith-based organizations. Those include organizations connected to governmental social services. And we are now looking for opportunities for partners who are at the point where they are ready to engage in a new strategy for supporting families. And so my students, we just got a funding for a Bass Connections team, which is a program at Duke that supports vertically integrated teams. So it's perfect for us. We have faculty, postdocs, graduate students at different levels, and undergraduates. And the idea that they mentor one another through a research project. So we've combined these things and engaged our students, trying with each one to shape what they're interested in from a global perspective and keep those same concepts so that they remain passionate about their work, but figure out how that's almost or just as relevant here in the US.
Thanks, Eve. We are coming down to about 10 to 12 minutes left. I do have a couple questions from the audience, but Megan, if you can take 1 minute or 2 minutes to talk about your student, you know, how you rejiggered working with students, that would be great.
Yeah, so similar to Eve, I had plans to work with students. We have an SRT group that was going to be in Kisumu this summer, and then I work with, I have a doctoral scholar who had to change her, not just timing, but the structure of her research question because to incorporate the impact of COVID on some of the outcomes. And then we have 2 OBGYN fellows that we're planning to be in Kenya this summer. So as of now, the clinical work, you know, there is continuing. And so one of the fellows I'm working with has really been innovative and continued to work, and she's actually doing the first part of her project remotely with some additional support from staff on the ground there. But in the SRT students, we had to switch, and I think that's unfortunate because people really want the cultural and travel aspect of doing the research, but our team has been shown a lot of resilience, and I think research-wise, they've actually, you know, one group is working on producing a manuscript, and they're, I think, going to have something to be able to submit by the end of this semester. And then the other group, they pivoted and were able to do interviews with key stakeholders in Kenya. They were originally going to ask about the impact of the global gag rule on reproductive health services from both a high level and a low level, sort of on the ground perspective. And they were able to amend that survey instrument, and they got a lot of buy-in from key stakeholders who provided their time to do interviews. And they asked them about COVID and cervical cancer elimination and this whole bunch of questions, and just submitted their first manuscript to a political science journal that is looking at the impact of COVID and gender, or the intersection of COVID, gender, and health. And so, they're continuing to work on a report or write-up of the rest of their results. So, we're hoping that next year, maybe there will be some ability to travel, but I think planning wise, we're moving forward, thinking about how we can still engage with the team and the community there in a way that is mutually beneficial, but can be done remotely if need be.
Thank you. How about you, Kristin? We're also getting a question from Julia Curran in our audience. Will you allow students to travel for field research internationally next year? And what's your situation with students?
Yeah, I mean, personally, yes. It just depends on whether, Duke allows them to travel. But I usually have about 8 to 10 people who are here with me when I'm here in various capacities, working with the nonprofit, doing psychosocial support for the kids, research, and then clinical care, both from School of Nursing, Master's Global Health, residents, people from the hospital, people from other medical schools, from other programs who come out here. So this summer, I actually had 2 people who were here with me who are not from Duke, and without any issues. And I have the ability, we've created a huge research infrastructure here, so people can do work and research remotely with the data, with the information that we have here, with my research team that's on the ground, and research has actively been open again for several months here. So I don't think that's the issue. It's really just a safety thing. Again, Tanzania is a little bit unusual in that there are still COVID restrictions, in that we still wear masks in the hospital. KCMC, Bugando, not as much anymore. But it's just general personal safety, right? And but from a personal standpoint, I do feel comfortable with having people here, as long as you adhere to basic hand washing and rules. There are no longer any admitted patients in our hospital with COVID, and that has been for at least the last 3 weeks. We haven't had anybody, so I think things are turning around here.
Good, that's good news. Our audience member had asked a little earlier if the low diagnoses may be related to lack of testing. So I'm throwing that in there since you brought that up.
It's a combination. Low testing, yes, but also the population here, almost half of the population is under the age of 15. Mm-hmm. And we know that in children, the symptoms of COVID are typically less severe. And so I think that there's a very large portion of the population who actually had COVID or were exposed to it and had very minimal symptoms, and so never presented for testing. And the government here at least made it very difficult to get testing early on. And more recently, it's even more difficult. And so I think that, yes, there's a lack of testing. And so the case number is probably much higher than what is reported. But overall, I think the cases are lower here than they were in other parts of the world. Combination of tropical environment plus very young population, mm-hmm. and the very large rural population. So there's not a lot of people that are grouped together. So you automatically have that sort of social distancing built into the communities. So I think that the transmission was actually much lower here than it is, even compared to like Kenya, which in certain cities there's a much higher density. Dar es Salaam had much higher cases, but where I am, it's much more rural. So we didn't see as much.
Good. Since we know your connection is working at the moment, we have one last question for everybody. It's on a more personal note. The pandemic has changed all of us. What positive learning experiences have you had during this unprecedented time? How have you grown personally as a global health professional?
You want me to answer?
Yeah, it's kind of a long question, but just
Yeah,
personal insights, personal growth.
so briefly for me, one of the things that I struggle with a lot is because I am one of the handful, 3 or 4 people who practice pediatric cancer, I feel a lot of guilt and a lot of difficulty when I'm not able to be present, and when I'm not able to provide that care to people and support my team who are here. And I think personally what I learned is, and I'm not like tooting my horn, I don't do that very well, but what I learned personally is that the team here has been really well trained, and they are at a point now where even when I wasn't here for 5 months, which is the longest I've been away for the past 6 years, despite some issues, like a non-medical team, they were able to provide great care under the circumstances. And so I think I really learned that like the team is better than what, I always worried, and I think that they can stand on their own, and I'm really happy about that because I think it'll allow us to grow forward. As we have more peds oncologists who are being trained in the country. I think we've created a great infrastructure. So I'm really happy that I learned that by being forced to.
I think that's a reflection of your training and work too. So thanks, Kristin. Tolu, are you still there? Did you have any thoughts on your personal professional growth during this time? We have 5 minutes left.
Thank you. Yes, for me, I think one great thing COVID has done for us in my workspace is for us to really leverage on the use of technology. As a country, the private sector is ahead of the government in terms of leveraging, using technology to within the space. But with COVID, we've been forced to do it, and somehow we've been successful. Like in the last 2 months, we reviewed guidelines, and we were able to do that with about 100 people, I think, in attendance and across different parts of the country. We were able to do that successfully. It was something we thought was not possible because in the past years, what we do is that we have a meeting of 5 days and we come together and do it physically. But this time around, we were forced to do it virtually, and it was quite successful. We were able to finish the guideline, and hopefully soon it will be out in print and available. So one thing that the example has really taught us is, the COVID has really taught us is that we need to leverage on technology, and through it also we've also been able to provide governance for our state officials. I work at the national level, and therefore we provide oversight to state governments, and through technology now, the virtual platform, we have trainings for them, we have meetings regularly. Those meetings were not holding before because we felt it had to be physical, but now we were able to have more oversight through adopting the virtual platform.
That's a great point, Tolu, and bringing up technology. Thanks for adding that. And I think people would say the same here in the US. A lot of us have had that same experience. Eve, can we pop over to you and just get some final reflections on your own growth as a global health professional?
Sure. I think it's also related to technology. We all do a lot of our global work via technology all the time. So I expected a smooth transition. And I think I've realized that I need, recognize how to be a more intentional mentor, because you lose a lot of the casual interactions, checking in on students a little more, fostering a positive environment, and learning how much you depend on those initial connections with community partners, even if you then have to do it virtually. So we're working really hard to try to figure out how you build community relationships without that personal contact when the people are literally 2 miles away.
Yeah. And thanks, Eve. And Megan, we've got just 2 minutes left. Do you have anything to add?
No, I mean, it has been a challenging time. It's been, you know, I think that personally, you know, there's been waves when you have to like embrace more and more meetings, and the fact that you can take advantage of everyone's time and energy in like really wanting to connect over Zoom. And I think that's great. And then sometimes I think you need to step back and say, for your own health and sanity, maybe you don't need 9 hours of Zoom calls a day. And I think learning to say that's okay is okay. I mean, I've also learned how to cut my kids' hair, so that's been a personal growth that I'm proud of.
That's our next Zoom talk. That'll be our next Think Global.
Yeah, it's time for another one. I can do a live show.
Thank you. Thank you, panelists. You are amazing, and we wish you continued luck in your work, and we hope that things will go back to normal by this time next year. Thanks to our audience for attending. We are so thrilled that you could come, and we hope you'll keep an eye out for our next Think Global talk. This will end our session. Thanks.